Hello, my name is Manuel Celedon, and I'll be presenting a novel metric for identifying naloxone distribution from the emergency department in high-risk patients. These are learning objectives for the lecture. According to CDC data, opioid-related overdose deaths are increasing, with synthetic opioids being the main driver of overdose deaths. Veterans treated by the Veterans Health Administration have almost twice the risk for accidental overdose compared to the general US population. This data necessitated the development of risk mitigation strategies for combating the epidemic. A recent study by Dr. Allison Lim found that opioid overdose rates among VHA veterans increased because of increases in heroin and synthetic opioid use. Veterans are still overdosing despite substantial reductions in the receipt of prescription opioids. The findings highlight the need to broaden the overdose prevention efforts beyond patients that are actively receiving opioids. At our Veterans Health Administration, academic detailing services have championed national strategies to mitigate the risk of overdose in veterans. The Veterans Health Administration Opioid Safety Initiative, or OSI, and the Opioid Overdose Education and Naloxone Distribution Program, or OEND program, have effectively educated patients and providers on safe opioid prescribing practices. However, there are changing trends in the opioid overdose epidemic among veterans, with many turning to synthetic instead of prescription opioids. So the academic detailing services at the VA have created an OEND program as one component of their overall effort to provide effective treatments for opioid use disorders in a manner that minimizes risk of adverse events. Similar OEND efforts have been deployed across the US and outside of the Veterans Health Administration. They provide risk mitigation initiatives that target patients with opioid use disorder and/or opioid prescriptions to prevent overdose deaths. As the name implies, there are two components to the program. One is education and the other one is distribution of naloxone. The last decade has seen a rise in the number of opioid-related ED visits, with ED visits nearly doubling over that time span. The rise in opioid-related ED visits and the 24/7 nature of EDs provide an opportunity for future interventions in patients with OUD or risk factors for opioid-related overdose deaths. The difficulty is in streamlining the identification of these patients and incorporating that into current ED workflows. Despite public health advisory from the Surgeon General, and the advent of OEND programs across the US, opioid-related deaths are still rising. And even though we've increased the number of OEND programs, they're only present in about 8% of US counties overall, and in 13% of counties with the highest density of overdose deaths. Additionally, these programs were primarily focused on primary care and clinics and pharmacies, and really shows that the ED presents another opportunity for further expansion of access to take-home naloxone, with studies showing that if we intervene in these patients in the ED, we can reduce the risk of overdose. So the great divide here is the fact that we just don't have enough of these OEND programs around. And we have a hard time, at least in the ED, identifying the at-risk individuals. To further highlight this fact, we have a map of the US here depicting counties with the highest overdose mortality rates, which is the dark blue, and the number of OEND programs in the US, which are the orange dots. And it shows that there are a lot of dark blue areas without any orange dot or OEND programs. And so again, the difficulty here in the ED specifically is trying to identify these patients, since there are a variety of ethnic, racial, socioeconomic, and different health factors that alter the risk profile. And then additionally, the data on the changing trends of the opioid epidemic shows that we can't just focus on patients that have prescription opiates. We need to look at patients using synthetic and other illicit opiates. And so safe prescribing practices, developing safe prescribing practices are not enough. We need to find ways to identify these patients as they come into the ED so that we can provide them with life-saving naloxone. One interesting risk factor that's a strong predictor of subsequent overdose deaths is the frequent ED utilization in the previous year. Studies showed that higher rates of ED use within these groups indicate a higher likelihood of overdose death. And so getting all this information and collating it in a way that's easily digestible by providers on the front line is what's needed to bridge the gap between our knowledge and what's going on the ground. And so at our Veterans Health Administration, academic detailing services have played an integral role in providing a centralized approach to improve education across the VHA facilities. They developed our OEND program and created clinical dashboards that help guide the facilities on the front line. And so what is academic detailing? Academic detailing is a scholarly approach to balanced, evidence-based information that uses direct one-on-one social marketing techniques to provide service-oriented outreach for healthcare professionals. Academic detailing at the Veterans Health Administration has influenced naloxone prescribing rates. One study showed that providers exposed to academic detailing, the blue line, had a higher average prescribing rate when compared to providers that were not exposed to academic detailing at the VA, the red line, and this difference persisted at the 2-year follow-up date. The Veterans Health Administration Academic Detailing Services also create clinical dashboards, and these clinical dashboards are platforms that integrate multiple data sets, data structures, into a single interface that's easily visualized and understood. They provide real-time or near real-time surveillance of a healthcare system's progress. And we were able to, our academic detailing services were able to incorporate a lot of our data into a dashboard that we use at the VA, and that's the ED Opioid Safety Initiative dashboard, of which one component is the Naloxone dashboard. And this Naloxone dashboard tracks the % of at-risk patients presenting to the VA, EDs or urgent cares that receive Naloxone at ED discharge. And as you can see, our national numbers show that there's a lot of room for improvement. So since only about 2.5% of patients showing up to VA urgent cares or EDs are getting naloxone at ED discharge. And these are patients that are at risk for overdose death. And so the dashboard provides the data in different formats. It even gives you provider-specific data where it shows the number of unique patients that each provider saw that were at risk for overdose death and were not prescribed naloxone. And it also provides very detailed reports that will help leaderships in the urgent cares and the EDs to figure out which patients require follow-up and what patients are at risk, so we can better identify them. And in our dashboard, we defined patients that at risk for opioid-related overdose deaths if they had positive risk factors, as well as they had an ED visit and were not discharged with naloxone, ED or urgent care visit and were not discharged with a naloxone prescription. And we noticed that we were able to create a metric, the missed opportunity metric, which is basically the dashboard identifying patients at risk for opioid-related overdose that were not given naloxone at ED discharge and were sent home without naloxone. And there are some limitations to our dashboard. It does not track non-Veterans Health Administration visits or prescriptions. So if a patient went to an outside hospital and was prescribed naloxone, we would not be able to track that. And it also relies on the electronic medical record having accurate diagnosis information. But ultimately, the main point of the dashboard is to act as a signal for action and not so much, we understand the limitations, but it's mostly to provide a signal for action for the troops on the ground. And so the Veterans Health Administration is divided into several areas called VISNs, or Veterans Integrated Service Network. And we reviewed the data for our VISN at Greater Los Angeles, VISN 22, from July to September. Our VISN consists of 8 facilities in the Southwest United States. And we identify that there are about 24 patients at risk for opioid-related overdose deaths, and only about 20 of them, or 1.1%, received naloxone at ED discharge. And so this showed that there are 98.9% of at-risk patients were not given naloxone at ED discharge, and that represented a potential missed opportunity. The national data is very similar to our local data, with about 0.9% of patients receiving naloxone at ED discharge during that time frame that we reviewed the data, and 99.1% of them having been identified as missed opportunities. And so next steps, we noticed that the rate of naloxone prescribing by Veterans Health Administration ED providers for patients at risk for opioid-related overdose death is low and is highly variable. And so we need to develop a metric that tracks these missed opportunities so that we're able to better identify patients and prescribe naloxone at ED discharge and decrease the variability of that prescribing pattern. We need more research to determine the validity of our metric and clinical dashboard to recognize the gaps in the prescription of naloxone and find ways to decrease the variability of identification of patients, as well as provide metrics and data to guide providers in an audit and feedback method to promote naloxone distribution from the ED. Thank you.